Today's guest has devoted her career to advance diversity and equity in both healthcare and research. Last year, Dr. Nakela Cook was selected as the Executive Director of the Patient-Centered Outcomes Research Institute, or PCORI. She spent the previous 12 years at the National Heart, Lung, and Blood Institute at the NIH, where she was the Chief of Staff and Senior Scientific Officer for the 1,000-person and $3 billion institute. In her spare time, she was a practicing cardiologist. If you want to know where to eat a heart-healthy meal in Boston, you need to ask Nakela. Dr. Cook graduated from Harvard Medical School and the Harvard T.H. Chan School of Public Health, where she also served as a fellow in health services research. She completed her training in internal medicine and cardiology at Massachusetts General Hospital and fellowship in minority health policy at Harvard Medical School. Dr. Cook has won numerous awards, including the William A. Schreier Award for her promise as a young investigator in cardiology, the MGH Fellows Award for Excellence in Clinical Teaching, the University of Alabama Birmingham Outstanding Young Alumni Award, and the American Heart Association Young Investigator Award. We are delighted to welcome the groundbreaking leader, Dr. Nakela Cook, to Chet Talks. Nakela, thank you very much for joining us.
Oh, it's just my pleasure to be here. Thank you for the invitation and for the kind introduction. I look forward to this.
In 2012, you wrote, quote, "The ideal effort to reduce disparities is to prevent them from ever occurring among all people, irrespective of race." How can we prevent disparities from ever occurring?
I really appreciate that question. And you're taking me back in my years and thinking about this real devotion I've had to dealing with issues of health disparities throughout my career. And they really were inspired by growing up in Alabama and seeing just the, say, vast disparities that really existed in cardiovascular care and cardiovascular outcomes at the time for me. And it was then I decided I wanted to devote my career to thinking about leadership and health and addressing these issues. And so that statement, I believe, was really driven by what I think we've come to understand today as a pursuit for health equity. And that if we really achieve health equity for all communities, then we're preventing some of these disparities and outcomes from ever occurring. And I have this incredible fortune to lead this organization, the Patient-Centered Outcomes Research Institute, which has really understood from its inception the importance of addressing health disparities. And we've been thinking about some of our new proposed priorities for health that are going to drive our future. And we recently released those for public comment, but within them is this concept of health equity. And it's woven throughout all the priorities, as well as really being captured in its own boldly stated goal, which is just achieve health equity. And I would say that if you're paying attention to everything that's happening around us, we've just seen the disparities and significant burden on patients, families, and communities magnified during the COVID-19 pandemic. And we've seen Black and Hispanic individuals nearly 3 times more likely to be hospitalized and twice as likely to die from COVID-19. And this is really, I think, brought to the fore this importance of preventing these health disparities from occurring at all, because they have such a devastating toll and consequence on our populations. And in many ways, I think of patient-centered approaches and patient-centered outcomes as inherently about health equity. But I want to say one other thing to your key question, which is my belief that we have to get to some of the root causes to try to prevent these disparities from occurring at all. And we focused for many years on dealing with some of the comfortable issues in terms of trying to address what's happening in terms of access to care, or really focusing on what's happening in a hospitalized or clinical setting. But what we understand in terms of preventing disparities is we've got to deal with the root causes around the legacy of racism in this country, dealing with the social determinants of health that are embedded in the social determinants embedded in policies and practices and communities that are at this point, I think, showing us the devastating differences that can occur with populations. And we have to be really comfortable with identifying those issues, naming them, thinking about interventions to address them, and following up with data-driven approaches in terms of how we measure the effectiveness of those interventions. So What a nice start to our conversation, because I think it's just critical for us to really pay attention to all these opportunities and banding across sectors to prevent these disparities from occurring.
Any of these root causes related to social determinants of health that you want to call out in particular as important?
I would. In fact, I think that one of the things that I feel we have seen over the last year is just an urgency in terms of call to action to address the issues of racism in this country. We've seen this in social justice movements, some spurred on by the death and murder of George Floyd and so many others that were before and after him. And so I think one of those root causes that we really have to address, and is part of our social determinants of health, is racism, discrimination, and bias. And we see that show up not just amongst racial and ethnic groups in this country, but the discrimination and bias is present when we think about differences by geography, when we think about ableism and other types of issues that have really come to the fore. And so my sense of dealing with social determinants of health is the structures that have been, I think, really reflective of the systemic and structural racism, the income inequality, and other types of things are part of those social determinants of health that we have to address if we're going to get to root causes of health disparities.
You spent much of your research documenting many of these disparities, including disparities in access to care among the uninsured, differences in cardiovascular outcomes among women and men, utilization of defibrillation devices among Blacks. PCORI has long funded research aimed at reducing these disparities. What has worked?
I love that question, and it allows me the opportunity to really mention why I think PCORI is such a phenomenal place in our research ecosystem and place to work. And it's this focus on patient-centered outcomes that I think are inherently equity-minded, and the fact that PCORI, from the very early stages of funding research, identified addressing disparities as a core national priority. And as we're moving forward, we are doubling down on that and really thinking about the issues of health equity that are serving as an umbrella approach to the important undergirding foundational work around addressing and eliminating disparities. But one of the things that I think has really been unique about PCORI's funding is that our funding actually has explored in many ways a population focus around racial ethnic minority populations. We've also had many studies that focus on low-income women, older adults, rural communities, LGBTQ communities and populations. And while a lot of our studies focus on a specific condition rather than really disparities per se, they're comparing two different treatments or delivery methods within those populations. And what we've seen as one of the promising strategies for reducing disparities is that of using community health workers who are typically lay members of the community who may share ethnicity and language, socioeconomic status, and life experience with other community members that they serve. And they play a vital role in enhancing the trust between communities and researchers. And we've had over 75 studies that have been either underway or completed in this area. And several of them that use community health workers as an intervention have shown improved outcomes. For example, there's one study in an asthma population who received community health worker visits. And what we found is that they experienced fewer days with asthma symptoms as compared to those patients who didn't have community health workers as part of their larger care protocol. And another example is a study that was looking at reducing heart disease risk factors, something that's near and dear to my heart, in rural Appalachia in a community in Kentucky. And again, here, these community health workers focused on classes that taught the local community about weight, blood pressure, smoking, depression, and overall heart disease risk factors. And we actually found in that study that the patients that attended those classes had overall reduction in heart disease risk more than those who just received a physician referral to go on to see a cardiologist or a nutritionist, et cetera. So that's one strategy that I would highlight, is really the utilization of members of the community that really understand the community. But even beyond community health workers, we've seen some other promising things in reducing disparities. And the other one I may highlight is when there's been follow-up from with a patient with simple phone calls or interaction that goes broader than just receiving something like a mailing as a follow-up from a physician, has really shown us that it's been important in terms of following through on the recommended suggestions from the clinical encounter. In this case, it was colonoscopy, where a physician really wanted to recommend colonoscopy for a patient, but that follow-up phone call is what made it happen and helped to reduce the disparities in colonoscopy rates amongst different populations. And this was based on the Hispanic population of middle age. But I think there's some things in common in those strategies. And for me, it's that tailored, focused approach that's very population specific that seemed to work in these scenarios.
As a reminder to our listeners, you can put, we're going to take questions from Dr. Nakela Cook from you. So if you just put those questions in the Q&A, we will get to those in a little bit. You mentioned COVID-19 and the disparities that has unsurfaced. One of the disparities is around vaccine and vaccination rates. Is there a role for community health workers in trying to address some of the disparities related to vaccination for COVID-19?
Well, what a fantastic question. And because, you've identified this very important issue related to the fact that even as the vaccines were developed, we faced this challenging circumstance that those that were most devastatingly affected by the disease needed to be incorporated in the research and studies that were going to help us with the development of the vaccines. And that was actually something that I think we saw the biomedical research community really try to rally around in terms of thinking about the ways to increase historically underrepresented and disadvantaged individuals in that research and those studies. And I really do think that if we're going to focus on eliminating disparities and achieving health equity, it's going to take a multifactorial approach and a multi-sectoral approach. And this is going to include not just participating in the research process, but building trust. And we think this is going to be key to both research participation as well as the implementation of those findings. So now that we're at the point that the vaccines are here, implementation requires increasing the trust in the communities. And we have certainly seen that community health workers have that tie to increasing trust in the community. So I like that point that you raise about the potential opportunities for us to leverage some of what we've learned already in our community health worker research portfolio that can be helpful in the implementation at this stage of our challenge with COVID-19. I'll mention we at PCORI have started something that we've developed over time called a science of engagement analysis. And we have an approach at PCORI where with research, we require an engagement of the patients and the stakeholders throughout the whole research process, from the identification of the questions of interest, through the review of the merit of an application, all the way through to the dissemination and implementation of the research findings. And I think that actually can provide some insights for us as we start to think about how we may help to alleviate and some of the differences that we're seeing in vaccination rates now, because as we move from research that has shown effectiveness to now the struggles of implementation, I think an engaged approach can really build trust in thinking about how we want to provide the answers that people really need to understand what vaccination can do for them. So if I had to sum it up, I think it's about meeting communities where they are, and community health workers are certainly a part of that, to really engage them in an authentic and humble way and allow their lived experiences to come forward for us to really understand the issues that are important to deal with the trust and allow us to work through how we get to the vaccination decision that will improve their health outcome.
You mentioned the vaccination trials, which actually did a reasonable job of including individuals from underrepresented groups in the Pfizer-Moderna trials. 10% of the participants were Black, 20 to 25% were Hispanic. Why were those studies able to succeed in getting underrepresented groups to participate in clinical trials, whereas many other studies have not?
Yeah, well, I do think first and foremost, there was a recognition of the importance. And that importance was driven, I think, by the fact that we both were seeing these remarkable disparities in COVID-19 rates of infection as well as mortality. And that was being reported across public health communities across the country. So it was really undeniable. And the second is that if we were going to stem the tide on COVID-19, we were going to have to do so amongst the communities that were most adversely affected. And then I will also mention that I think there was a lot of wisdom in the way in which the companies actually began to say, what are some of the best practices in getting the enrollment rates from the communities that we're really trying to reach. And one of the interesting things is that at times there was pause actually in recruitment in order to get certain communities recruited into the study that really needed to be represented. And we see that in research studies, like the need to really say, if I'm committed to having a certain level of diversity in my study, I may have to think about different approaches, such as halting recruitment in general populations and targeting recruitment in other populations in order to make sure we have a diverse representation in those clinical studies. And we saw that happen. I also think that beyond the trials that may have done something successful there, is that there are really valid reasons for some of the participants in historically underserved and excluded communities to distrust medical research and the medical research enterprise. And these are based on historical experiences that are real. Many of these communities have experienced oppression as well, and they've seen their lived experience and cultural knowledge discounted in trying to participate in studies and other research efforts. And so our PCORI work has taught us that stakeholders can sometimes feel like when you approach a community that you have a check the box kind of attitude and are not genuinely listened to. But what we would encourage as researchers think about opportunities to really diversify their participant pools is trust has to be earned. And we have to show members of our communities that have been underserved that they're worthy of our trust and that we value their lived experiences and that we continue to try to build and rebuild that trust through continuous, meaningful engagement. And so, though we may have seen something in the vaccine trials, I think we have a lot of lessons learned about how we do research with communities moving forward.
As many people know, I'm a big fan of her books. So if you haven't read Harriet Washington's book, Medical Apartheid, that's an outstanding book that lays the foundation for why there is this distrust among many groups with both healthcare and research. I want to switch gears a little bit and think about diversity in training. In the 1960s, less than 10% of American medical students were women. Today, more than half of medical students in the United States are women. Why?
We've certainly seen amazing progress in terms of the gender breakdown of medical school classes. And since the 1960s, as I heard you say, slightly more than half of medical students now being women. And I have to say, reflecting on my own experiences, I benefited from the hard work and sacrifices of many who paved that road before me and joined a medical school class that was approximately half female. So I was really fortunate in that experience. But in looking at the bigger picture, I think it's clear that there's still so much work to still do before we really see the relative equality that we now see at the medical student level. And while I may not know all of why we are where we are now, it does tell me that we still have a lot more to do when you start to look at the ranks of leadership in academic medicine. And so, you know, according to some of the most recent reports from the Association of American Medical Colleges, 41% or almost 50% of medical school faculty are now women, but only 29% are at the level of division chiefs, or 25%, a quarter of full professors. And it's even lower when you start to look at department chairs and dean roles. And so under 20% of those types of roles are held by women. So I would say that remarkable progress doesn't mean we have the ability to stop here. We still have a lot of effort to to put forward. And I think that focus on understanding the desire to want to reflect the diversity of our nation and what we do in medicine and in routine clinical practice is an important way to think about why there really is this imperative for us to continue to move forward the opportunities for women in leadership ranks in academia as well.
By contrast, there are fewer Black men in medical school in 2014 and perhaps today than there were in 1978. So fewer Black men in medical school in the United States in 2014 than a generation earlier in 1978. Why is that?
It really is a sad statement in terms of the racial and ethnic breakdown. And we've had, I think, regression rather than progress in some spaces that you're mentioning. I recall a study that was published in the Journal of the American Medical Association a couple of years ago that showed the percentages of medical students who identified as Hispanic actually increasing from about 5% to nearly 9% over the years of 2002 to 2017. And the percentage for Asian Americans also increasing from about 21% to about 25%. But when looking at Black medical students overall, the increase was fairly marginal from 6.6% to about 7.3%. And then when you look at Black males, as you described in medical school classes, another article that was published in the New England Journal of Medicine showed a drop from 3.1% to 2.9% over 40 years. So not equivalent, but even dropping. And in real terms, there's been this decrease. And the reasons I think may be similar to the types of reasons we talk about for disparities in health outcomes. We're dealing with issues of systemic racism, inequities in access to education, housing, mentors, community support. And I believe likely income inequality plays a role as well. We know that the cost of a medical school education is going higher and higher, and that many of the individuals that we would like to see diversify our medical school classes are coming from populations that may have traditionally been lower income or living in underserved or historically excluded communities where systemic racism has been very prevalent. And so I think that those are barriers to really trying to make a movement and a trend toward a different direction in our medical school education. And I would also say that there definitely are in some of the reports I've read an absence of Black male role models as well in our early education, in our K-12 education system, especially in the science disciplines, and a difference in schools available to students by race. And so those are the types of things that I think show up much later in the educational process as well. So I think it begins early, but it certainly does compound over time. And I think we're looking at the same types of drivers in the reasons we don't see diversity in the medical school education as we see in terms of the disparities in health outcomes.
Yeah, questions coming in. So if you have questions, please put them in and we'll give them to you. Maybe we'll get a relatively short answers so we can get through many of these. Dr. Sam Frank from Boston University says, building trust with patients may be easier with stable, known staff. In my experience, there's a high turnover of positions such as community health workers. Do you have suggestions or insights on how to reduce this turnover?
Oh, that's a fabulous question. And, you know, one of the things that I think it may be really helpful to think about as we start to think about turnover in these types of roles is when we've kind of looked at what's worked in the research setting in terms of engagement, the sustainability piece becomes very important, and communities are really interested in not just having an attention or a focus during the time period of a study, but really what does this mean for the longevity in that community? And I think there may be in our projects and our clinical endeavors and the ways in which we are conducting research with communities, if we're working with community health workers, conversations that may be important to have about the sustainability plan for the type of interventions, the type of work that's happening in the longer term, even beyond the turnover and the other things that may occur. And I also find in some of the work we've done to evaluate the engagement of and regarding research in communities is that the lived experiences and the suggestions and solutions that come from those communities are often the ones that are the most sustainable. So having that opportunity to really pose that question in the communities and hear the opportunities for solutions, I think is a really important one as well.
Another question, how PCORI study outcomes have been integrated into legislation?
Oh, that's also a phenomenal question. And the outcomes that come from our clinical research studies are related to comparative effectiveness research. And so we're studying different strategies, different interventions, and understanding what works. And we have a commitment through our legislation, as well as just through what we think is the right thing to do at PCORI, to make those research results public. And we do that by posting things on our website, pushing it out in different ways. And we have very focused dissemination efforts working with our stakeholders that are engaged. We also convey all of those results to policymakers. But where I think our results have the biggest impact in terms of clinical practice and helping others inform their decision making is actually in the movement from results to guidelines and clinical practice decision support tools. And so we spend a lot of time and effort focused there. It's less about the incorporation in the legislation, but more about the applied practice and making sure that we, by our mission, are helping individuals make more informed decisions and getting that information out to them for the clinical care that they're trying to seek.
Lots of people thanking you for your service at PCORI. This question is, how can our national agenda address extreme health disparities, help bridge partisan stereotypes, for example, rural versus urban, about what health disparities are, and bring more people together in productive conversations across the political spectrum?
I love that question too, because it really speaks to the breadth about disparities. Because as I mentioned before, we talk a lot about health disparities related to race and ethnicity, but they're really present along many other parameters. And I even mentioned geographic disparities when I gave an example of a study that was conducted in rural Kentucky. But there are disparities in health status and access to care by socioeconomic status, by age, by sexual and gender identity, many other things. And so to me, it becomes less partisan when we start to really realize that the breadth of what we're talking about in terms of health disparities affects everyone in this nation. And I think the concepts that are really important around patient-centeredness and thinking about health equity is around everyone having the opportunity for the best health outcome they can have. And I think that crosses all lines. And speaking to it at that frank level, I think tries to bring it out of the partisan debates and more into the all Americans debate and trying to do something for everyone in this country.
One last question from our audience, and I have a final wrap up, and we'll try to do this in 2 minutes or so. General advice for private company or startups on obtaining funding from PCORI. Are they eligible to receive grants, and how they go about applying?
Yeah. That's a great question. We have a broad stakeholder community at PCORI. It's patients, healthcare providers, clinicians, advocates, caregivers, private sector, Congress. We think of our mandate as really being responsive to anyone that's involved in the healthcare environment. And so we certainly have worked with the private sector in many of our opportunities, and we have engagement awards, we have research awards, and we have dissemination and implementation awards. And we would love to be able to speak with you further about opportunities and how to apply through our solicitations. If you haven't done so, we had an interesting webinar a few months back that's archived on our website that just talked about PCORI funding opportunities for 2021. And that's an easy introduction. It's a quick webinar, but we can certainly go further, and feel free to email us from our general information box on our website, and we'd be happy to talk with you about the funding opportunities.
Last question for me. So you've been an executive director now, Dr. Cook, of PCORI for the last 18 months. maybe what has surprised you the most in a good way, and then maybe what surprised you the most in a bad way, been disappointing?
Oh, this is such a great question. And I have to say, entering this role in the midst of a global pandemic was certainly not what I anticipated. So maybe that's one of the things that surprised me the most. But it's been incredibly revealing and has yielded some remarkable learning opportunities. So there's a silver lining in that. And I've been pleasantly surprised by the dedication to PCORI's mission from everyone I meet. And I expected this from our staff and our board, but the remarkable element has been the PCORI stakeholder community and seeing the commitment, the support, and the inspiration. And that's been really unparalleled in my experience. And maybe what I would say is been most disappointing is I haven't had the ability to engage in the way that I'd hoped in terms of getting out there, having the listening tour, talking around the table, hearing the priorities for PCORI from all that have really supported the organization over the years and helped to create this incredible foundation that we have to build on for PCORI's future. And I just couldn't be more excited about where we are and the opportunities on the horizon. You know, we have our reauthorization behind us and dedicated funding, and we're moving forward boldly to build on the pillars of the first 10, 12 years. So this is an exciting time for us. And I appreciate the time for the interview today, the questions that have come in, and the opportunity to talk with your community.
Well, Dr. Nakela Cook, thank you very much for all your leadership. We're looking forward to your road tour, maybe a road trip with Dr. Cook. We'll start in Boston with a good heart healthy restaurant and visit all the various communities that PCORI and that you serve. And to our next talk, the Center for Health and Technology at the University of Rochester, thank you very much for joining us. And thank you again, Dr. Cook, for all your great service.
Thank you. It was my pleasure.